This is 11-year-old girl, Rima, okay, referred for evaluation of short stature. Her height is below 0.4th centile. Okay, you have to do examination for her, general examination for her. Okay.
Okay. Okay.
Okay. 4 minutes, then you can start.
Okay.
Okay, start.
Okay. First of all, I will introduce myself, take permission from the mother, and do hand hygiene and go to Rima and make rapport with her. So whether she is communicating or not, I will observe.
Well communicating.
Okay. Then I will check for whether she has any dysmorphic features on the face and also any unusual features on the hand in exposed area. Anything I can see?
Can you just see for the face and comment if you see anything?
I can see only the pointed chin. Other than that, I think
Okay.
the face looks normal for me.
Okay, yes.
And yeah.
Next
Okay.
one.
And then I would like to check the weight and height and plot in the growth chart.
Yes, her height is below 0.4th centile. It is 126 centimeters.
Okay. Then I would like to check the midparental height. And also I would like to check the target centile.
Okay. No need, you can proceed.
Okay. Then any special surrounding, anything I can see? Any aid or
She has
any glasses? Yeah.
She has a hearing aid in the right ear.
Okay.
That's it.
Okay. Okay. Then I would like, and she is well looking, right? No
Yes.
distress,
Yes.
anything?
Well
Okay.
looking.
Okay. Then I will start.
Go ahead.
Okay. Also, I would like to check if possible in all the exposed area, if any skin rashes I can see, like any hyperpigmented patches or any hypopigmented patches for this child.
No skin rashes.
Okay. Then I would like to check from the hand. I will check for any anything in the nails, like any abnormal nails.
No.
Okay. Then I'll check for any clubbing, any pallor, any jaundice in the palm. Also,
No.
Okay, then I will check for any bony deformities, and I will tell her to make a outstretch her hand to look for any asymmetry.
No asymmetry.
No trident hand.
No.
Then I will tell her to make a fist to look for any fourth and fifth metacarpal shortening.
You don't see
Okay.
that. Okay.
Okay, then I'll tell her to keep on the side, two hand stretch to look for the carrying angle.
No carrying angle.
Then I'll tell her to touch the thumb to the shoulder. Then I will check the pulse.
Can do it.
Okay, pulse to look for any the rate, rhythm, character, any radiofemoral delay.
80 minutes, 80 beats per minute. No radial or no radiofemoral delay.
Okay, then blood pressure. Then I will check the axilla to look for any hair in the axilla. Then proceed to the face to look for any pallor or jaundice in the eyes.
No hair in axilla. No hair in axilla. No pallor and jaundice in eyes.
Okay, then I would like to check the mouth to look for any high-arched palate, any cyanosis, any dental problems.
No problem, normal.
Any ulcerations, pigmentations?
No, normal.
Okay, then in neck, I would like to check for any visible veins, pulsation, and also any neck swelling.
You can see the neck. There is no neck swelling.
Normal.
Yeah,
and also any webbing of the neck, if anything, I would like to check that.
Yes, but there is very little, not obvious webbing, but very little. Okay.
Okay. Okay, then I will go down to the chest and look for any breastword, any abnormal thoracic cavity like pectus excavatum or carinatum, any scar mark, any visible pulsation.
No. In the chest, you can see a scar in the center of the chest only. That's it. No other findings.
Okay. Okay. There is any shield chest or any widely placed nipple?
No.
Okay. Okay. Then I will proceed. Then I'll just observe the abdomen, any scar mark and any gastrostomy tube, anything in
No.
observation. Okay. Then I will proceed with the chest cardiovascular examination. First of all, I will check for in inspection already I saw. So I will palpate and look for the apex bit by putting both the hands. So where is the apex bit?
It is in the fourth intercostal space, mid-clavicular line, left side.
Left side. Okay. Then I will palpate all the four area in the apical area, lower left sternal border, upper sternal left sternal border, right upper sternal border, and also carotid pulsation with if any thrills or any palpable pulses, I would like to check.
No thrills or no palpable pulses.
Okay. Okay. Then I would like to check for. I will check for. I will auscultate for the heart sound in all four areas.
Yes, it is normal. S1, S2 heard. No added sounds or murmurs.
Okay. Also, while palpation, I would have seen this this parasternal heave. Any heave?
No parasternal heave.
No. Okay. Then also I will check the sides in the axilla, below the axilla, if any thoracotomy scar is there, and also if it is going to the back.
No thoracotomy scar. Time finish, 6 minutes. So you can present.
Okay, so in order to complete my examination, I would like to complete with the abdominal examination to look for any abdominal mass, mainly any kidney, palpable kidneys. And also I would like to do the complete Tanner staging and look for any scar mark on the femoral area, any edema anywhere. And also the back to look for any kyphoscoliosis.
Okay.
So today I examined SURAH. She looks short for her age, not well looking, and not in distress. On examination, also, okay, on examination of the hand, it is normal. There is only, I can see there is on inspection, there is some webbing of the neck. Other than that, general examination is normal. On examination of the chest, there is a mid-sternotomy scar on inspection, and otherwise there is no murmur in the chest. And other examination looks normal, and only the weight is below 4th centile. Yeah.
Okay, so give your height. Height was below 4th centile.
Sorry, height is below 4th centile. Yeah.
Give your differential diagnosis.
As she is a girl with a short stature, first of all, I will check if mid-parental height, and I'll put if it is familial short stature. Also, I would like to rule out the constitutional delay by asking the onset of the puberty of the parents. And then there is webbing of the neck and with some median sternotomy scar. So most probably it's a case of Turner syndrome. Yeah. And other possibility, I would like to keep like any chronic illness to be ruled out, like any chronic, like any renal failure, or but this child weight looks normal, so most likely other chronic illness unlikely in this case.
So how do you want to investigate this patient?
This patient, first of all, I would for diagnosis, I would like to do the karyotyping, and also I would like to do a ultrasound abdomen to look for any ovaries, streak ovaries, and hormonal assay, LH, FSH, estrogen, testosterone levels should be done. Also thyroid function test, and also
this patient.
Sorry.
You said testosterone. You want to do testosterone in
estrogen, estrogen level,
okay.
And thyroid function test and bone age. So I would like to do the wrist X-ray for this child.
Okay.
And as there is a sternotomy scar to see maybe if any underlying illness, so chest X-ray, ECG, echo if needed.
Okay. So how do you want to manage this child's short stature now?
Okay, so this child needs multidisciplinary team involvement, including the pediatrician and the endocrinologist to consider for growth hormone treatment. And other than that, cardiologist to look for any underlying cardiac illness already mostly the child will be following up with, and any dietitian if needed for the nutritional support. And also if child has any psychological issues, so psychologist and psychiatrist may be involved.
Okay.
And also if any problem with educational support needed, then educational healthcare plan needed.
Okay. What are the indications of growth?
And genetist also if it is Turner. Yeah.
What are the indications for growth hormone therapy?
Yeah, indication is Turner syndrome, Prader-Willi syndrome, then any cases with the IUGR babies who are not grown by 4 years of age, also Russell-Silver syndrome, then any chronic renal failure cases if they have, and yeah,
And now
and
this
SOX
child,
deficiency. Hmm?
okay, this child is now
SOX.
11 years old. The starting growth hormone now will help her.
It depends on her bone age, and that will be decided by the endocrinologist if it is going to help for her. If it is yeah, looking at the bone age, they will decide.
Okay. 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 Finish. Let's enough. I will ask you in your examination. You height was given to you. You asked for mid-parental height and target centile, but did you ask that you want to check sitting height?
No.
Here it's important, right?
Yeah.
Yeah, because it is short stature. You should ask for, if you would have asked for sitting height, I have written here the sitting height.
Okay. Mm-hmm.
Yeah. I wrote here 63 centimeters to tell you. Total height 126 centimeters, sitting height 63 centimeters. So you did not ask, I did not tell you. Okay.
Mm-hmm.
This was one thing you missed. Otherwise, I think you covered most of the things and you were able to. You did all maneuvers of short stature, I believe. You asked for the star fist and you said checked for the carrying angle, and you also asked for the keeping the thumb on the shoulder, right?
Yes.
Anything was missed? I don't remember except sitting height. Bending is there in this maneuvers or no? Bending in front.
Back is there, back.
Yeah, back. I think she did not check. She told in order to complete my examination, she did not tell the. She did not check the back.
Back is there. And Dr. Noor, this patient had a hearing device, na? So
Yeah,
can
yeah.
can
When she was told that there is a hearing device, she would also had a look at into the ear, which she did not tell she wants to see, and I did not tell her anything.
Okay.
Can it be Noonan, Dr. Noor, differential diagnosis? Because Noonan is autosomal dominant.
Yeah, differential diagnosis you can give Noonan also, but in girls the top will come Turner's. And here you can put the top differential instead of this CDGP and familial. Turners, because some features were given to you, like webbing and also the scar in the chest. Okay. Based on that, you
Yes.
can keep Turners as the top. At the same time, you have to rule out, you told very nicely that you want to check the mid-parental height and also take the history from the parents if this is delayed. Okay. If you were asked the question, how do you define short stature? What will you answer?
Doctor,
Yeah,
Wait, let her answer, and then I will give you a chance. Yes, tell me.
yeah. If the height centile is below second centile, below, yeah.
Any comparison to the mid-parental height?
Mid-parental height, yeah, mid-parental height, if it is 2 centile below the mid-parental height, then it is short stature.
Yes, 2 centile below the mid-parental height. And also there is one more, just 1 minute.
Dr. Noor, can I ask one question?
Short stage, 1 minute. I will just finish this definition and then I will listen to you. So short stature is defined as height that is 2 standard deviations below the mean height for age and sex. Suppose if you keep the mean height for age and sex, if it is below the 2 standard deviations, also it is defined as short stature. And also, as you said, two standard deviations below the mid-parental height. I have a doubt here. In the patient info, he has given 3rd centile. I want to go back and check the growth chart about this. I will share now and then we can discuss, no problem.
this is you are reading from NHS, Dr. Fatima.
I'm reading from patient info.
Yeah, so it must be right only. There is no doubt about it.
3rd centile.
And even
below, he's
in,
not below 2nd centile. He's telling below 3rd
Yeah.
centile, or the mean height for the age and sex. Less than 2 standard deviations from the mean height of age and sex,
Same.
or less than 2 standard deviations from mid-parental height, and less than 3rd
Same.
centile. He's telling, he's not telling 2nd centile. Maybe this is the new one. I don't know.
No 2nd centile he has mentioned, because in Nelson he mentioned 2nd centile.
But here he has written 3rd centile. Let us see the
Sorry, 2 standard deviation. Sorry. 2 standard deviation. Has he written something? 2 standard deviation? Hello?
Just wait, I will share the definition for you.
Here it is written in the mark, short stature is defined as the height less than 2 standard deviation score below the mean, that is less than 2nd centile.
But Mark, okay, I do agree with you. I don't know what is the most recent definition by the NHS.
Yeah.
Because Mark is now 2016. We are now 2021.
Yeah, this 2 standard deviation is okay because there is in the chart, but there is no.
Yeah, it is there in the chart, and also here also
Yeah.
it's mentioned. This is okay, but 3rd centile is the one which is confusing me here.
Yeah.
See here, he has told short stature is defined as height that is 2 standard deviations below the mean height for age and sex. Both you can take. If it is below 2 standard deviations from the mean height of for age and sex, as well as more than 2 standard deviations below the mid-parental height. But in general, he is telling less than 3rd centile. So I don't know if this, we have to tell 3rd centile than 2nd centile. This is the new, but even from before I remember, it was less than 2nd centile, right?
Yeah, this too I remember because this was written in Nelson also. Less than 2 standard deviation height and less than 3 standard deviation for microcephaly.
Okay. Okay. Let's keep this and search some other places and see. Okay. Short stature is defined as height that is 2 standard deviations below the mean height for age and sex, less than the 3rd centile, or more than 2 standard deviations below the mid-parental height. A child's rate of growth is important. A down growth trend suggests a slowdown in growth, possibly a growth problem. A growth velocity disorder is defined as abnormally slow growth rate, which manifests as height deceleration across 2 major percentiles on the growth chart. If it crosses 2 centiles below, you should be careful.
Hello?
Just 1 minute.
Hello?
Yes, just 1 minute. So primary growth disorders, which you should know, is clinically defined genetic syndromes. That is Down syndrome, Prader-Willi syndrome, Russell-Silver syndrome, Noonan syndrome, Turner syndrome. Okay, at least keep these 5 syndromes in your mind. Downs, Prader-Willi, Russell-Silver, Noonan's, and Turner's. Then intrauterine growth restriction with failure to catch up. IUGR, okay. Then congenital bone disorders such as achondroplasia, hypochondroplasia, and osteogenesis imperfecta. But here you will have disproportionate short stature, right?
Yes, yes.
Yeah. So, but the above what we read in Downs and Prader-Willi, Turner's, all you have proportionate short stature. So always when you comment on short stature, comment whether it is proportionate or disproportionate. Then for these were the primary. For secondary, you will go for the endocrine causes like hypothyroidism, panhypopituitarism, hypothalamic or pituitary lesions, maybe tumor or trauma. Then growth hormone insensitivity, which is also known as Lawrence syndrome, Cushing's, growth hormone deficiency, precocious puberty, disorders of growth hormone, insulin like growth factor. Okay. Then metabolic, you can put mucopolysaccharidosis, glycogen storage disorders, and chronic diseases. Any chronic disease like cardiovascular, renal disorders, hemoglobinopathies, respiratory, you can put for the differential. Then malnutrition, that is poverty and neglect, IBD, celiac disease, bowel obstruction, enzyme deficiencies. Then psychosocial deprivation also can be a cause for short stature. Medication, steroid therapy. So history, we all know, we will take for the parents' history about when did they have maturity, was there, if they had constitutional delay in growth and puberty, that has to be checked, and familial heights has to be checked to see whether it is familial, and also nutrition history, past history of chronic diseases. What we said, the causes has to be excluded here. Then examination, accurate measurement of height and weight, sitting as well as standing height are important in order to consider asymmetry and skeletal disproportion. Example, achondroplasia. So never forget sitting height in a case of short stature. A thorough physical examination helps to differentiate abnormal growth patterns from normal variants. identify specific dysmorphic features of genetic syndromes. So unusual features has to be checked. Consider growth hormone deficiency. So look for other features of pituitary hormone deficiency like hypogonadism and possible features of pituitary tumor, papilledema, and visual field defects. Yes. Also, in order to complete my examination, you will also mention BP and fundoscopy in any short stature case, because you should also rule out CNS tumors. Okay, even though the child is fine, you will do your complete your examination with BP and fundoscopy. This was not told, I think, by Dr. Sridevi, right?
Yes.
Yeah, because you see what he's telling, you should also look for other features of hypogonadism and also features of pituitary tumor like papilledema and visual field defects. But I think you asked about the vision. In examination, in order to complete, you should include fundoscopy as well. Consider any indications of other possible underlying causes like Cushing's, chronic kidney disease, hypothyroidism, fetal alcohol syndrome. Look for other features of Turner's syndrome in girls. Look for features of skeletal causes like rickets, achondroplasia. Look for skin lesions, cafeolate spots, and large hemangiomas. Calculate expected final height. Mid-parental height provides an estimation of the expected final height. If the child height lies within the target centile range, then their height is normal with regard to genetic potential. Okay. Still we are using this formula. I don't know in the growth chart. I don't know if still we are using this formula. Mid-parental height is equal to father's height plus mother's height plus 13 divided by 2. And for girls, minus 13 divided by 2.
Obsolete now, obsolete since long.
I don't know when this patient info is also reviewed. We have to check it back because
Actually, this is almost same if you calculate, no? So plus 7 minus 7. It's same like if you're adding 13 and dividing by 2 is 7.5. So not much difference. It's only 0.5 difference only. Okay. The way they have put is different. Otherwise, the value is almost same.
okay.
Actually,
Wait. Here you will add the father's height plus mother's height. To that you will add 13 and then you will divide by 2, right?
Yeah.
Yeah.
Okay. There they will add father, mother, and then divide by 2 and then plus 7.
Okay.
Yeah. So it's almost same.
Yes, Dr. Yasser, you are the one who was speaking.
actually, Dr. Krishna is right. This is obsolete, and actually, they are now providing the graphs. Calculation is right, no problem. But they are providing the graph, and in the graph, we have to learn how to we have to plot the mid-parental height. We have to plot on the right side the mother height, and then the left the father height, and then we have to mix them and you plot them. The 2 points we have to match them, and the in between the point comes is a mid-parental height.
You are right.
Yes.
This
Yes.
was
Yeah. That is right.
in my mind. That's
Yeah,
why
and
Yeah.
then in the chart when we calculate the mid-parental height in the child, we don't go 7 point or 8.5 centimeter above and below the mid-parental height. Nowadays they are saying 2 centile above, 2 centile below. That's finish. So don't be confused in calculation, especially in exam, because time is very short and it's very difficult nowadays. You know, time management is a big issue.
if he is 2 centile within the 2 centiles from the mid-parental height, he is safe. No problem.
He's normal. He's normal.
He's normal. Yeah.
Yeah, he's safe. And that this mid-parental height is to differentiate between either this is normal or abnormal. It means if it is low or abnormal, if it within the graph is normal. And the third thing, we are confusing the this exact height, the height the person achieve at the puberty, at the age of 18, that we call expected height. That's another formula, other the chart that's also available on this RCPCH website, the growth chart. So please be particular regarding this handling these
Yeah,
charts.
that is target centile chart, right?
No. Target centile chart is the target between the mid-parental height.
What is the other chart you are telling now?
Wallah, 1 minute, I will forget the name of that.
Dr. Noor,
Hmm?
you know the growth charts given on the RCPCH website?
I know.
The one,
We have to review them actually. Yeah, tell me.
yeah, the one which is 2 to 18 years, because there is one which is 0 to 4. There is one for neonatal, one for
It's called adult height predictor. Sorry,
yes,
adult height
yes.
predictor.
It's on the right hand
Okay.
side. There are two. There are kind of areas, two boxes. The top one is for calculating the mid-parental height, and the below one is for the adult predicted height. I actually opened this morning, so I know that.
Mhm.
Yeah,
Yeah,
but you will find it there, inshallah. Yeah.
yeah, we have to review it again to know the things. Yes, investigations indicated. The common investigations is the blood tests, okay, FBC, then renal function tests and electrolytes to rule out what? Renal diseases and electrolyte abnormalities like Barter's syndrome, diabetes insipidus, and other renal and metabolic disorders. So you'll tell full blood counts, renal function tests, liver function tests, thyroid function tests, ESR, CRP, chronic inflammatory conditions, urine analysis and urine pH level for renal tubular acidosis. Then karyotyping is very important in this patient. May be helpful where examination suggests features of genetic syndromes. It should be performed in all girls with short stature, as this may be the only feature of Turner's syndrome. Okay. So even if all your examination of is normal, still you will mention karyotyping in your investigation if this is a girl patient. Specific tests for suspected underlying or associated disease like celiac disease, Cushing's disease, cystic fibrosis, growth hormone deficiency, and vitamin D deficiency. Bone age is very important, helps to predict final adult height by estimating skeletal maturation from the assessment of ossification of the epiphyseal center. Okay, no need all those things. They have a standard. I know how they see. The endocrinologists have a standard atlas with them. Here he has mentioned, no, this one, Grulich Pile Atlas. They will compare the child's X-ray with their atlas and then see how much deficient it is, like what is the difference between the chronological age and the bone age. Bone age is considered delayed if it is 2 standard deviations below the chronological age. For everything, 2 standard deviations is very important. Even short stature, 2 standard deviations below the mean height for age and sex, 2 standard deviations below the mid-parental height also. And even here, bone age is delayed if 2 standard deviations below the chronological age.
Only in case of microcephaly, 3 standard deviation.
Okay. So familial short stature, usually bone age is normal. In CDGP, it is usually the bone age corresponds with the height age and is delayed up to 2 standard deviations. Okay. In CDGP, in children with pathological short stature, it will be more than 2 standard deviations. So you should know this. Familial, it will be same as chronological age. In CDGP, it will be up to 2 standard deviations, or you can say it is delayed. Definitely it will be delayed. In pathological, it will be more delayed.
There is a standard deviation for bone age?
He has mentioned, yes. But I think no need to mention. If they ask, you can say, but you should know that it is delayed in CDGP. Okay. If they ask about any standard deviations, you can say up to 2 standard deviations. No need for dental age and all. We'll go further. Then referral. Indications for referral include height. Height fails to progress along the appropriate centile curve. Decreased growth velocity for age. Genetic potential. Projected height varies from mid-parental height more than 5 centimeters. Okay. So at least if the child is up to 5 centimeters from the mid-parental height, he is less, no problem. But better to tell in the standard deviations, that is 2 standard deviations. Remember that, that's enough, I feel. Again, he wrote bone age, management. Management, we should know about growth hormone because they will ask this question. Okay, growth hormone. Growth hormone of human origin, somatotropin, has been replaced by growth hormone of human sequence, which is produced using recombinant DNA technology. Okay, NICE recommends the somatotropin to be used for treatment of growth failure in children who have growth hormone deficiency, then Turner syndrome, Prader-Willi syndrome, and chronic kidney disease. Born small for gestational age with subsequent growth failure at 4 years of age or later. Have short stature, homeobox containing gene, SHOX deficiency. So here, small for gestational age, SGA is also an indication, but you will start at the age of 4 years, right? Below 4 years, I think you will not start this treatment. Any comments for this? And
You
he
are right.
mentioned here Russell silver. Is, I think in Mark it is there, right? Russell silver. Yes, Dr. Yasser, you're telling something.
No. Mark indicated only these 4 or 5 indication that FDA approved. Russell silver they use, but there is not FDA approved.
NICE approved.
No. NICE did not approve. NICE only 5 these condition.
Yeah, no, Russell silver does not come under the approval of NICE, you're telling.
Yeah.
Okay, so this only growth hormone deficiency, Turner syndrome, Prader-Willi syndrome, chronic kidney disease, small for gestational age who are not catching up growth above 4 years and above, and SHOX deficiency. Treatment should be discontinued if growth velocity increases by less than 50% from the baseline in first year of treatment. Final height approached and growth velocity is less than 2 centimeters total growth in 1 year. That means if less than 2 centimeters overall growth in 1 year, I think there is no effect. So it has to be discontinued. Adherence is poor and cannot be improved. That is poor compliance, difficult to improve. Then final height is already attained. Means if there is closure of the epiphysis, you cannot continue it. So you should know when you should discontinue growth hormone therapy. Less than 2 centimeter catch-up growth or throughout the year, and poor compliance and you cannot improve it, and final height already attained. One more thing is growth velocity increases by less than 50% from baseline in the first year of treatment. Okay, I want to also know about the adverse effects of growth hormone. Let's read this and then we'll talk. Growth hormone therapy in children with idiopathic short stature seems to be effective in partially reducing the deficit in height as adults, although the magnitude of effectiveness on average is less than achieved in other conditions for which growth hormone is licensed. What we read above is the licensed conditions. Okay, idiopathic short stature is not considered there. Treated individuals remain relatively short when compared with peers of normal stature. Okay, this is, I don't know, some growth hormone. Mecasermin, a recombinant human insulin-like growth hormone, is licensed to treat growth failure in children and adolescents with severe primary insulin-like growth factor deficiency. No need to go in details. Next, anyone, before going to complications, can anyone tell me the Side effects of growth hormone.
Okay, they have this lipoatrophy, hypertrophies. They have many related to the bone, like they have arthritis, they have SUFI, and also they have the scoliosis. Okay, and other than that, they have endocrine related hypothyroid and this diabetes. And also they have this benign intracranial hypertension.
So and also, is there obesity also? Child can become obese as well or no?
Obese, I don't know.
No, no,
about
no.
that.
Because in Prader-Willi, we are using to reduce the obesity, this growth hormone. So I think so. It's not causing obesity.
Okay. Children with short stature may be teased or bullied with potential emotional and psychological consequence. This is a source of parental anxiety, although in general, studies are reassuring and suggest long-term complications are infrequent. Because short stature causes anxiety and may prompt consultation, it may draw attention to underlying conditions which may be get treated and consequently improve the general health. So always in your management, you should, if it is a history case, explore the social problems, emotional, behavioral issues, bullying, school performance, psychological consequences, very important. Okay. Later you can go through. But if anyone gets about this, is this the recent definition? Just check it back. If you get from other sources, just let me know. Because I want to know about this third centile here in the first para. Okay. Dr. Krishna, you're here. Hello.
Yes, yes, yes.